Well, thank you everybody for coming. My name is Anna Walter and I'm a project coordinator at the University of North Dakota Center for Rural Health. And I'm just kind of sitting in for Ashley, who's been here on the other calls. Just want to welcome you guys, and we're meeting here today with Deborah Lane for the final webinar on care coordination with a focus on community outreach. All of the previous recording and slides that Deborah did do throughout the last several weeks are uploaded and available in our virtual library. So if you do need your access to that, please put a little note in the chat box and I will reach out to Ashley and have her get that to you as soon as possible. And then this recording and slides will also be available very soon. With that, like Deborah said, if you just add an on, if you would put your name and organization that you're representing in the chat box, they would like to record your attendance. With that, I guess I will turn it over to Deborah.
All right, thank you, Anna. Well, welcome to the last in a series of webinars focusing on care coordination. In the first webinar, we focused on what was called or is called the Care Coordination Canvas. And I guess simply put, the Canvas is a way of helping you to develop a workflow for your care coordination program. In the next webinar, we introduced a concept called community care coordination, which reaches beyond the walls of your healthcare organization or your clinic in caring for your patients. And we'll bounce off of a number of those concepts and kind of use it as a springboard for what we're talking about today. In the third webinar, we heard some real life examples of how to apply this canvas when reaching into your community. And a few weeks ago, we discussed making a business case for care coordination. And today we are going to focus on reaching into the community by identifying and engaging those community partners. As Anna said, I am Deborah Lane. I am a program specialist team lead with Rural Health Innovations. Many of you know about our organization, but if you're new to this, Rural Health Innovations is a subsidiary of the National Rural Health Resource Center. And our organization's work focuses on improving and sustaining health in rural communities like yours across the country. By the end of our time together today, it is my hope that we will be able to recognize the community resource partners, or those partners that you need to really do effective care coordination for your patients. I want us to think back to that second webinar and recall some of those methods of determining social determinants of health. And then I want to talk about community influencers and how to start to recognize who those people are. Then by the end, I want us to determine how to engage partners. And finally, for you to be able to select some ways to sustain those partnerships. We started our journey together at the end of April by learning about the Care Coordination Canvas. As I said, it's a way of ensuring that you have all the necessary components of a successful care coordination program. An effective workflow that connects your patient and the care team. And there are 4 quadrants: your target population, or that patient, the assessment, and the care plan, which are the ways of communicating to the care team. Those 2 quadrants kind of, as Nadine said, connect the patient to your care team. And Nadine was one of the persons that talked about how she and her hospitals use the Care Coordination Canvas. But there are 2 other elements to this canvas, and they're really key, very important considerations when considering the success of your program. And those are collaboration, and care coordination may be that linchpin for healthcare transformation, as we talked about in our last webinar, but collaboration truly is the linchpin for effective care coordination. And then social determinants of health are those things that affect a person's health beyond your clinical walls, which is a key part of that whole community care coordination concept. In our time today, we're going to focus on these last two sections of the canvas, on collaboration and using those social determinants of health to determine your partners. These two elements are the backbone, as I said, of community care coordination, which, to refresh our memories, is a collaboration among healthcare professionals, clinics, hospitals, specialists, pharmacies, mental health, community services, and other resources working together to provide person-centered care. As a healthcare industry, we much more naturally look to clinically related partners, such as specialists and pharmacists. And it's not as natural for us to look outside of our walls to community services and resources that can work with us to improve our population's health. So today, we will begin looking beyond our walls. You may remember this slide. And I'd like to really quickly review the benefits of community care coordination for reaching outside of the clinical realm. I think that you're going to see the benefits to both you and your organization and to your patients. When we reach beyond our walls and into the community, there just simply is better coordination of services and care provided to your community as a whole. In a moment, we're going to revisit a slide that shows 20% of a person's health is attributed to their clinical care. So in light of that, in order to affect the other 80% of a person's health, we need to coordinate care with those partners outside of our walls. If you remember, community care coordination is all about the collaboration between clinical entities and community services to provide person-centered care. There's greater collaboration and better communication among leaders and providers. As providers strive to obtain better outcomes for their patients, there's a greater need to collaborate outside of our walls, because that provider can only affect 20% of that person's health. So intentional community care coordination, or intentionally reaching out into the community, brings community leaders and providers together, thus bettering communication and strengthening collaboration with the patient in mind. When we reach into the community, we see increased promotion of local health care and social services. As I think about it, it's really like this two-sided coin, where when you refer a person and connect them to a community service, those community services are being promoted. But when the community service is working with your patient, the other side of that coin, that community organization is going to be encouraging them to come back to their primary care provider, promoting your healthcare services. So reaching into the community is all about really providing and promoting the right care or service at the right time, in the right place for that particular person. There's enhanced marketing to better promote services and quality of care. Reaching into the community is no longer just the healthcare organization all by themselves. You're not in it all by yourself. The other healthcare professionals, clinics, hospitals, specialists, pharmacists, mental health providers outside of your organization, and those community services and other resources are really promoting your services and your quality of care. The whole community, in a sense, truly becomes a promotion arm of your healthcare organization, because you're allowing them to know what you're doing. They're understanding it, so they're able to promote it. There's greater community awareness of available resources and services when you start reaching into the community. It's a natural benefit of the collaborative effort, which means greater awareness of what your healthcare organization offers, but also what is available in the community from other organizations. This can be a real win for your organization as well as those community organizations and community members, because they're aware of what is being offered right in their own community. There's improved community perception of local businesses, hospitals, and clinics. The focus of all organizations participating in your care coordination program is improved health of your community members. When the community begins to understand this, there's an improved perception of the businesses working within your project, within care coordination, but also your organization, because you truly care about them. A big benefit, and from our standpoint here, what we often see as one of the greatest financial detriments to smaller communities is the bypassing that happens. And so when we start reaching into our community, that chance of bypassing, or we see reduced bypassing of local businesses local businesses of that healthcare provider, because the community begins to understand what services are really offered locally. And the likelihood of community members going elsewhere is reduced, often really resulting in that bypassing is much reduced because people are simply aware of what you do. There's increased patient loyalty when you start reaching into the community, and also increased employee satisfaction. In community care coordination, or when reaching into the community to work with community partners, patients see their needs being met by your organization. Even if you're actually not doing the work yourself, they're seeing it that you were the one that referred them to that organization. And then that organization that you refer to becomes an extension of your healthcare organization, all increasing loyalty of your patients. But your employees are starting to see things being addressed by those community organizations that may have been overlooked for years. And when they see these things addressed, employee satisfaction increases, because quite frankly, they don't feel like they're beating their head against the wall again for one of those unmet needs. So reaching into the community creates that patient loyalty, but also employee satisfaction. There's increased alignment of local services to community needs. When the community embraces your care coordination program, the collaboration, in a sense, that's formed identifies those gaps in services and addresses meeting those needs. There's improved reimbursement, increased local revenue and earnings, and jobs for greater economic growth. When you reach into the community with your care coordination efforts, it'll affect the bottom line of your organization and the other organizations that you collaborate with. There are reimbursement mechanisms, as we talked about in the last webinar, for such things as chronic care management, or CCM, and TCM, transitional care management, which really are community-based. And your efforts reaching into that community is a very important aspect of making those successful. New local services may be developed affecting your local economy, Another big piece is that bypassing isn't happening, nor is that out-migration, because that will bring more revenue to your organization simply because community members become aware of what is right in your own community, all bringing increased employment, opportunities, and really affecting economic growth in the long run in your community. We talked about value-based care last time and how value-based care is affected by care coordination. Care programs better position you for those population health measures, the quality improvement, and so forth. So community care coordination, we talked about being a linchpin for value-based payments. And I want you to remember that value payment formula that focuses on quality and on cost. And when you start reaching into your community for community partners, it just does that. It improves quality, it improves the experience of the patient, and it really addresses the whole person. Excuse me. There is a detailed look at community care coordination and its benefits. Community care coordination, or when you start reaching into that community, there's many partners. And knowing what the social determinants of health are for your community is the foundation for determining your partners. You've seen a visual similar to this before, and we realize that 80% of a person's health is determined outside of the clinical realm. It's determined by their behaviors, by the environment that they live in, and by many social economic factors. And our partners are who augment our healthcare organization. Those partners are the ones that we work with that will affect our care coordination efforts. To refresh our memories about social determinants of health, these are the other conditions that affect a person's health. They're the conditions and the circumstances that people are born, grow, live, work, and age in. These circumstances are shaped by a set of forces beyond the control of the individual. Things like economics and the distribution of money, distribution of power, social policies, politics at the global, national, state, and that local level. And this is from the World Health Organization. The use of a combination of lived experience, your community health needs assessment, secondary data analysis helps you make a complete list of those social determinants of health for your given target population. And it's very effective and helpful to do this as a team because you all have different lived experiences. And using the social determinants of health worksheet for this will help guide you in this process. And we talked about that in our second webinar. It's also a piece of your community or your care coordination canvas guide. And so using that as a base to start listing those social determinants of health for your community, then starting to discover who the partners are that you can bring in. And those are the ones that address those social determinants of health. When you're listing your partners, you may very well find certain partners address a number of social determinants of health. And those are key people to start bringing in as persons to be working with your care coordination program. These can be found in community resource directories. Sometimes they're housed in different agencies in your community. Perhaps your organization has a resource directory in your electronic health record. Other county public health departments have one of these. And in some communities, there's a nonprofit that focuses on putting together a resource directory. Your personal experience will also tell you the places to go for solutions. Most likely you've lived in the area for a long enough period of time that you know if you have a patient that has food security as an issue, you'll know exactly where to refer them to. Or if they're having some sort of problem with doing a ramp or doing something in their home, you'll know who to refer it to because you've just lived there. And there's just a lot of places to take and find who are these people that meet your social determinants of health. And in our office hours coming up next week, I'd love to spend some time talking with you on discovering the different partners in your communities that affect your social determinants of health. The Social Determinants of Health worksheet is designed really to help you do this. On the left side in that bluish green teal column is where you spend time listing and determining what those social determinants of health are based on your personal experience, based on the data as well. And then the two columns on the right side, those white columns, are there for you to start to write down who can meet those social determinants of health, who works towards solving them. And again, this worksheet is included in Appendix C of your care coordination guide. Obviously, the organizations that meet your various social determinants of health for your intended population are those that you want to pull into your care coordination efforts. And knowing what the primary ones are really key, so you can pull those persons in or those organizations in first. One of your social determinants of health is food, food deserts, food insecurity. You might want to consider bringing in partners like a grocery store, community garden, farmers market, maybe the school's meal program, food pantries, WIC, to name a few. If housing is one of your social determinants of health, you might want to include emergency shelters, assisted livings, long-term care, along with housing authorities or transitional living. And these are just a few examples of organizations to be pulling in. So by completing that worksheet, you're able to identify those community entities that address your social determinants of health. And so now you're starting to think about these different organizations in your community. And it's like, well, what do we really want to do with them? How many? Well, I want us to take and change gears here for a moment. And I want us to think about how we want to engage these partners, how we want them to most effectively work with us. And then we'll go back to talking about partners. We need to consider what type of involvement that will be most helpful to the community partner, to us, as well as to our patient. And these are the four main types of engagement that I usually work with when we're talking about building a community effort around something. And that would be either collaboration, forming a coalition, or cooperating with each other. So let's take a moment and look at each of these separately. An example of a collaboration would be from a community that I worked with that identified mental health services as a great need. So all the agencies, healthcare, and community-based organizations came together and did some strategic planning around how they can actually work together to increase access to mental health services. It was separate entities coming together to move forward as one unit. And that may be something that you're thinking about when you see some major needs in your community. And it would fit right into what your workflow is developed by that canvas. Then there's building a coalition. There was a community in rural Missouri that identified substance use as an issue in their community. So they established a coalition of various local and regional entities working in the area of substance abuse. As they reported what each of them was doing, they could see some common overarching areas, or I call them buckets in a sense, that they could work on together, and that their work amongst all of them kind of fell into 4 or 5 basic buckets. And so they began focusing on each of those areas in each of their meetings. In some cases, there were some new initiatives developed, but for the most part, there were individual initiatives by different organizations that were really supported by a number of community partners. So they didn't do that strategic planning together. They came in and said, this is what we're already doing. So if we're all working on something similar, like 4 or 5 areas of something similar, let's work in those areas together. In a community that has a large influx of immigrants to staff the area's agriculture-related industries, they established what they called a task force. I look at it as a cooperative effort. The various agencies with the immigrant population met monthly to inform each other about their efforts. Often they find areas that they can work together on, but mainly they make sure that they support each other's efforts by having complementary timeframes or timeframes that build off of each other. Back to the example of substance use. If one cooperating agency or organization was going to have a medication disposal drive, all of the other organizations would encourage their constituency to participate in that medication disposal drive. If another organization was thinking about doing it as well, they would actually put all of their efforts behind helping that one that was already a little further along in doing that kind of a drive. And that would be an example of cooperation. So how do you anticipate these partners being involved? And I'm guessing for many of you, it's like, well, I guess I haven't really thought about it. And it's a new area for most healthcare organizations. There's one, the very center, we call that core circle. And these are the people that do most of the day-to-day work and most of the planning. And they are involved in the development of the plan and its implementation. They can always be counted on to step forward when needed. So if one of your social determinants of health that was really widespread was food insecurity, having some organization or a couple organizations that work a lot in your community with food insecurity, having them sit with you as you start imagining how can we get our patients referred to your programs, how can we find out if they actually came, and really the nuts and bolts of all of this, having them in that core circle from the very beginning. Then there's what's called the circle of engagement. And these are the people that are committed to the plan they might not meet the need of all of your patients and can be called upon when needed. So if we take and use transportation as an example, and when we come across a patient that needs help with transportation to meet their care plan, we would call upon them, and they would be there to help us do that and to engage with the patient. But they might not be there all the time. They aren't the prime movers and shakers, but gradually they may actually move into leadership and into that core circle as time goes on, as they understand how to be more involved. Then there's that circle of champions. And these are the people who typically hold positions of leadership in organizations that need to be committed to the work that you are doing. Typically, they're not involved in that day-to-day activity of implementation, but they're often the authorizers or advocates for your effort. So back to the food insecurity example, if the food shelf was housed in one of your faith communities, the champion for that would perhaps be the pastor or one of the leaders of the church, that they need to know what's going on. They advocate for it. They're a cheerleader for the effort, and they need to be kept apprised of what's going on at that big picture level. Then there's the circle of information and awareness. These are the people that aren't very close to the plan or its implementation, but they do need to be kept in the loop as things unfold. So that may be someone from public health. So they know what you're doing with care coordination, and so they can maybe figure out how to tie into it. There might be other organizations that provide services to your target population that don't directly affect some of the medical care, but they still need to be apprised of the work that you're doing. And these persons often move into that circle of champions or that circle of engagement. Then that final level is the circle of possibilities. And these are the long shots or the wild cards. They are the people and organizations that won't immediately be thought of as being related to your plan and implementation at first, but they may be interested in partnering down the road. I think about my local community. There's a regional bus company, and transportation is an issue in my community, as it probably is in each of your communities. But to me, that LCS coaches is one of those possibilities, the circle of possibility, that they may become a resource someday to working on that social determinant of health. So just keeping them apprised of what you're doing is really an important piece, because down the road, they really may be an effective part of what you're doing. And so it takes some time, and just be creative and think out of the box of who some of those kinds of partners might be that you need to let know that our hospital is doing this project, and just for the sake of information. And as time goes on, they may be one of the persons that will become involved. So we have to think about who at what level.
One moment, as we're experiencing some technical difficulties, we'll wait for Deborah's connection to reconnect.
All right, am I back now? I have no idea what happened.
Yep, you're good.
All right. Okay. So actually, we ended at a perfect time. There must have been a glitch here with our internet, because everything just went. So I apologize for that. But I'm glad I figured out how to get back here. The normal Zoom isn't working, so I'm in on a website here. So anyways, thank you. So we talked about the kind of engagement that we might want from our partners. And now let's back to talking about partners. Who really needs to be at the table? Well, partners that have similar social determinants of health make sense. Partners that have similar clientele make a lot of sense. That those you're helping each other out, so those are natural people to be involved. Partners with lived experience. I often say when you're developing your care coordination program, and have somebody from that intended population sit with you to say, this isn't very realistic for us to do this kind of assessment this often or whatever, or this isn't the best way to communicate with me or my caregivers. This would be a better way. So consider having somebody from your intended population. Another piece is that, there might be some non-traditional partners to bring in, such as a youth group that could provide support to your Medicare population, or other civic groups that do things, do home repairs or whatever, if it is that Medicare population. And then there's some groups with some strong online presence that can really help you out. Then having some big picture thinkers, that's always an important piece. We don't always know the answers, and sometimes we need some of those big picture thinkers. Those persons that are more at a county or regional level are helpful. What about some of our assessment partners when you do your community health needs assessment? And then we're going to talk about this in a little more detail here in a moment, but bringing in opponents sometimes. It might be one of your providers, might be an opponent to care coordination, and especially reaching out into the community and having them work with you at developing that program, determining those partners from square one. You know what they're thinking, but the other piece of that is often they really understand what you're doing. And so they're more willing, and they'll become your champions. I've seen it happen many, many times. And then there's this category that I want to call community influencers. And I alluded to that a little bit ago. These are the people that are involved in your patients' lives. They may not be offering one of the services. We talked about if faith community has a food pantry, that the pastor is one of those persons that needs to be informed. Well, that pastor would also be considered a community influencer, because so much of our older population, they just listen to their pastors a lot. If they are in a faith community, there may be a person that's been a mayor for years, that might be still a mayor or no longer a mayor, but they're community influencers, people that are involved informally in your patients' lives, but that can influence them to participate. And making a list of who these people are is really helpful to know how to engage them. And those that would fall into some of that list of possibilities, but know who those community influencers are. So we should, who should we invite to this first part of expanding our care coordination effort into the community? You have your social determinants of health worksheet. You have your list of influencers. Might be long. So I want to introduce a new tool called partner mapping. Sometimes this is stakeholder mapping. It's a very common tool used in partnerships. And this really will help create a whole picture of your collaboration. There's three pieces to it. One is what kind of influence they have on the project. Another piece is what kind of impact does the project have on them? And then how do they feel about the project? Are they enthusiasts? Are they neutral? Or are they an opponent of it? And having the list of your stakeholders and identifying where they are in each of these areas is a very helpful thing to do, because it gives you a picture like this about, if I'm going to put my effort into inviting 5 entities to be part of our care coordination efforts, what 5 am I going to focus on? So here in this diagram, we have Eve, who you can see is a red circle, an opponent, who is an outpatient behavioral health provider. And then there's Kim, who is an inpatient behavioral health provider. And Eve runs her own business, where Kim works for the healthcare organization. Dan's a police chief. Joe is the county public health director, and he can influence the project, but it doesn't have a lot of impact on his work that he personally does. Scott is an ED nurse who it's going to have quite a bit of impact on him, but he can't necessarily influence your project. So I think we've gone over all of the people on this graph, but we really focus, as I said, on those ones in the top right-hand corner. And it can be just really an enlightening thing. And these are some questions from a formal stakeholder analysis, and called a partner analysis. But when we start looking at those persons in that upper right-hand column, and we want to bring them on board, we need to think these things through, because it'll be very helpful for us to take and design messages down the road, which we'll talk about in a moment. I want to use Eve as our example here. So when we're looking at those analysis questions, we may ask, what's important to Eve? Well, her running her own business, it's important that the patients show up, and patient privacy is important to her. So what does the group need? What do we need? We need patient adherence, because if our patients that have mental health issues are going to see their counselor, they're going to make progress. How will the work of this project help? Well, we can help Eve have increased adherence because we're in contact with that particular person and encouraging them to show up. How can we create that connection, or more clearly communicate that connection to Eve? Is that if she shares patient or information about follow-up calls that need to take place, we can share information with her, and we need to make sure that we have good policies created for that. So how we can make sure we modify what we're doing is to create a compliant release of information form, so we can be sharing that information back and forth. And how will we know if we're making progress? Well, if we're having regular meetings, is attending them, and we're seeing monthly sharing going on. So our 2 questions for this segment is, who are the partners that we should invite to the table, and how should we invite them? You have your 2 lists. You have your social determinants of health list, and you also have your community influencers. And when we're determining partners, we have to remember that health equity equation. And who are the partners that we can bring to the table to increase access, to increase participation, representation, and get better outcomes? So when we're thinking of partners, we need to think about that health equity equation. The potential partners worksheet, again, part of your care coordination canvas guide, is a place for you to take and record who these potential partners might be. Now, you've used your partner mapping, so you know who are the most important to invite first. So those are the persons that you would start to put on this potential partner worksheet. and writing their name, who would represent that organization, getting a person or a position there, what they can get out of, or what their potential role in your care coordination program is, and then what is in it for them, and start thinking about what it's in for them. And then the last three columns are about messaging, are about making that invitation. And so it's how are we going to communicate our need for them to participate in our program. Here's a list of questions, very similar to some of the things that we thought about in that stakeholder analysis. And again, these questions are included in your guide. And if we answer these questions for each of those potential partners, we will have ourselves prepared for the conversation that is coming up, and be confident in being able to ask them to be part of our program with us, and be confident of it, because we have to ask them, because that personal relationship is so important. Without a conversation, we can't build a relationship. The invitation is more than just time, date, and place. To be most effective, an invitation needs to be tailored for each individual. And we need to ask them or invite them to participate in creating a future that is different from the past or different from the present. The invitation is more than simply a request to attend. We're really asking them and inviting them to create a new future with us for the persons in our community. So the steps and pre-work should give you the confidence to ask those partners. In a sense, you have it scripted out, and making sure that you're explicit in what you're asking for. That invitation, when you're talking with them, is really to create that connection between the two of you, or whoever is designated to make that ask. And you need to ask them, not imply that they be involved, but ask them to be part of your program. So when you're issuing your invitation, remember to declare that possibility, frame the choice, name the hurdle, reinforce the request, and decide on the most personal form. Now, you've invested a lot of energy into this, and you're asking another organization or another person to invest. And so you want to keep that momentum going. So I'd like to talk real quickly about some ideas about keeping momentum going. And it might seem odd at the very beginning of something here, but keeping that momentum going is so important. And one thing that I have learned through experience is it's a lot easier to have ownership than it is to create buy-in. So back to our food insecurity example, if that's one of your social determinants of health, asking them to come in and help you figure out how we've identified this person as food insecure. Now, how are we going to get that name to you? How are we going to find out how all of these things, if they're there from that very beginning, they're going to have ownership in it. And you don't need to create buy-in, because buy-in is asking someone to participate in something that they weren't engaged in from the very beginning in creating. And then responsibility. And it's perfectly acceptable. And I think it just creates more engagement in the idea that, you know, giving them some real responsibility to say, okay, so why don't, will you work on the protocol, or what's going to happen in your organization? And then we can come back together and figure out how the two mesh. But making sure that you do give responsibility and not be afraid to do that, because you don't have to be the expert in everything. And then celebrate. Celebrate and share your accomplishments. You're going to be tracking data. You know if you're meeting some of your quality measures. Celebrate with all of your partners. Let their supervisors know. Let the community know. And then build relationships and community whenever you can. Because if there's relationships and community, everybody is tending to work more together. And setting goals and knowing your progress toward those goals. Your programs have goals. So making use of those as a way to create forward momentum is really important. And setting meeting dates early. Maybe for your care teams to be meeting, it's a standing meeting on the every other Monday or the third Monday or Tuesday or whatever it may be. Just set those meetings on a regular basis and have everybody bring their calendars. So before your meeting's done, you know when your care team's going to meet again. And then always remember continuous planning, that PDSA cycle, that planning and that doing and the study and then acting again and making any changes. Because our healthcare environment is changing so rapidly. The needs of our persons are changing so rapidly. We need to do that initial planning, but we need to update it perhaps more than annually and be intentional about retooling our program. We started out by talking about how to identify who should be at the table. And then after we had our technology glitch, we quickly went through ways of engaging them and some ways of sustaining and keeping momentum going. And wanting to finish in honor of your time here that you're giving me, I want to encourage you to join me next Tuesday for our office hours from 12:30 to 1:30. We can talk about ways of identifying who those potential community partners are, and then identifying the key ones perhaps to engage at first, how to engage them. We can practice issuing an invitation. We can run through the different tools that I very quickly went through here this afternoon. So I'm finishing with a couple minutes left. Does anybody have any burning questions that they would like to ask?
I don't see any questions, but thank you so much for your presentation, Deborah. We really appreciate it. And like she said, we hope you can attend her office hours on August 23rd. If you don't have a meeting invite for that.
I'm not hearing you, Anna. Maybe that's just a glitch with the platform that I'm on right now.
I hear you okay, Anna. You're okay.
Okay, I was like, I'm off mute. But yes, please try to attend her office hours on the 23rd. And I guess since Deborah can't hear me, we'll say goodbye.
Thank you, guys.